It's a great pleasure to be here today and to introduce Meeting Needs and Reducing Distress. This is guidance for the prevention and management of clinically related challenging behaviour. And this is we see as a key strategy for reducing restraint. So it's a real pleasure to be here today. Just very quickly, I'd just like to touch on what is clinically related challenging behaviour. Well, for us, it's any behaviour that results as a result of the clinical condition of the individual. So it's behaviour that can arise as a result of dementia, delirium, injury to the head or brain, substance abuse and withdrawal, alcohol abuse or withdrawal, learning disabilities, mental ill health. So you get the picture that it's actually behaviour that spans across the whole range of clinical conditions. But not only that, it's also behaviour that results in some kind of breakdown in the delivery of care. And what we're really saying as a key message as part of this project is clinically related challenging behaviour happens where a service area fails to meet the person's needs and fails to reduce their distress. And that's a key message for this project. It's a project that's acute focused in particular, but it does resonate across all services. So it has applicability across mental health and learning disability services as well. It was initiated for the acute sector, but I think it has a relevance across the board. So why has Nhs Protect delivered this project? Well, for a number of reasons. We have the remit for the safety and security of staff working in the NHS, and we collect annual figures on the reported physical assaults from health bodies, and these reported physical assaults against NHS staff show that 79% of all reported physical assaults in the NHS in 2012-13 are related to medical factors. And I think a key message for this conference is that we shouldn't just talk about patient care, patient safety. This is vitally important, but it's also staff care, staff safety, which is important, and that's the other side of the argument for this conference. But also, not only do we talk about staff safety, obviously we talk about patient safety as well. And as part of this project, between 2009 and 2012, NRLS data indicated that 15% of all restraint-related incidents caused moderate or severe harm to patients in the acute setting. A significant proportion of these incidents occurred as a result of security staff or police being called, either in isolation or in combination. So we can see it's got a staff and patient safety remit running through the whole of this project. So the project recognises that to keep staff and patients safe, you've got to create a proper therapeutic environment which can deliver the highest quality care, and that's the whole focus of this project. But the real strength of the work, and I think that this is why it's so important, is it's guidance that's been produced in collaboration. The guidance that you've got, and you should be able to pick up at the reception, and again, a bit of a plug, if you haven't got a copy of the guidance, go and collect it because it's very good, costs us a lot of money, very expensive piece of guidance, so I'd urge you to take it away with you and have a look through it. But the real strength of this piece of work is it was delivered by clinicians, nurses, doctors, trainers, and security experts working in the field. There was a 23-member expert group that put it together, so it's really clinically driven. Not only that, but we also represent the key stakeholders you can see on the screen as well. And all these stakeholders have given endorsement to this project as a key piece of work to reduce and minimise challenging behaviour. Just a very quick timeline in terms of how we got here. In 2000, the Department of Health launched the Zero Tolerance campaign against violence and aggression, and this was an extremely good starting point for dealing with violence and aggression and taking swift action where there's criminal culpability. NHS Security Management Service was our predecessor organisation. We took over the remit in 2004, and we developed the remit to focus more on the prevention of violence and aggression, and that's where we were coming from in terms of our national strategy. One of the areas of our national strategy was the launching of an ambitious national syllabus for conflict resolution training for all frontline staff working in the NHS. This programme was pretty much a success. We delivered what we intended to, but we started to recognise and get feedback from our key stakeholders that a significant proportion of all reported incidents of assault, particularly in the acute sector, but in all sectors, were due to clinical factors. Therefore, we introduced this project in 2011, and this was very much pre-Winterbourne View and pre-Mid Staffordshire. But following the initiation of the project, the inquiries into the abuses at Winterbourne View and Mid Staffordshire Foundation Trust took place. We also had the Mine Report, which highlighted the overuse of restrictive interventions and the unpleasant experiences as a result of service users being held in the prone restraint. So what we did, we made sure that we developed guidance that's complementary to all the other guidance that's out there and all the other guidance that's come on board since. We launched national guidance, training resources and a website in 2013, 2014, and this has been followed up by the Department of Health Positive and Safe programme in 2014, April onwards. It's heard mentioned before, it's a very, very complex landscape, and it is a very complex one. There's a whole plethora of guidance out there. The DHA are coordinating a 2-year positive and safe work programme to develop positive behavioural support and to minimise the use of restrictive interventions. And what we're talking about here is to bring about a cultural change, strong leadership, and improving professional practice to minimise the use of restrictive practices. So meeting needs and reducing distress really fits in with those aims and really can be seen in that context. But the key message, I think, for meeting needs and reducing distress is that don't think on its own about reducing restrictive interventions. First, think about preventing challenging behaviour in the first place. How can this be done? Through the delivery of good, high-quality, personalised care based on a good, quality care plan. And that's the key message for this conference as well. What we've got in terms of the meeting needs and reducing distress guidance is, I would say, a minimum standard for tackling clinic-related challenge behaviour. And I think that's important because it sets the baseline on which positive behavioural support and other strategies take place as well. It's a very complex environment, and again, I think a lot of trusts are struggling to grapple with this, especially in the acute sector. There's a lot of concern about how do we implement this, and I think the whole package has to be implemented together. So where our guidance fits in, it fits in with positive and proactive care, it fits in with positive and proactive workforce as well. And I think any organisational strategy has got to combine all approaches and manage it that way. Why is meeting needs and reducing distress important? Well, it's important for a number of reasons, because it's all about essentially protecting vulnerable people. 1 in 3 emergency admissions in the acute sector is a confused older person. We know that. Other patients who present in A&E have mental health problems, physical ill health, an injury. So you're trying to protect those vulnerable in the emergency departments. We also know that 1/4 of inpatients in the general hospital has a mental health problem. And that's a problem that all staff have to deal with and face. 60% of inpatients over the age of 65 have some form of mental health problem, largely dementia, delirium and depression based. So this is an issue, particularly for the acute, but for all sectors going forward. We also know that on top of having vulnerable people, hospitals are extremely stressful, busy, noisy, overstimulating environments. And when things go wrong, this really affects vulnerable patients in all sectors. But challenging behaviour also affects carers, relatives, family members, who only want the best care for their family members. But when things go wrong, family members, carers, relatives, they get distressed. That raises complaints, that raises a bad publicity for the organisation. So it's not just important for the patient, it's important for their family members and carers as well. But I've mentioned before, we're not just talking about patients, we're talking about staff. If staff dealing with patients are uncooperative, if patients are uncooperative, aggressive, difficult, it makes staff's life more difficult. It increases the risk of injury and violence against staff. So that's a key part of this work as well. And again, it's not just about staff and patients, families and the organisation. It's the organisational reputation which is key to this. Because if organisations can't get a grip on this agenda, then it leads to bad publicity, it leads to more complaints, it leads to more pressure from regulators as well. So that's what we're talking about. Getting it right is important for patients, staff, relatives and the organisation. What is our approach? Well, it's based on a very straightforward model. Essentially, what we want to do is make sure that physical interventions are used as a last resort. There's no doubt about that. And we also want it recognised that there are many stages to go through before physical intervention is even considered. And that's a key message. Clinic-related challenge behaviour is not a deliberate action by someone being drunk, difficult or aggressive. And staff need to recognise that and look and see beyond that, and see beyond the behaviour and look at the underlying causes. And that's a key message for the guidance. Essentially, what we're talking about is someone who has an inability to communicate their needs, communicate the reasons for their distress, and they're trying to communicate their needs in an unconventional way. So that's what we're talking about. Communication is the key strategy to tackle clinic-related challenge behaviour, and that theme follows the guidance from section to section. A unique feature of the guidance is the approach for high-quality, personalised care applies across the setting. Doesn't matter whether it's health or social care. The approaches that we've got in our guidance are applicable across the board, and I think that's one of the real strengths of this work. There are 3 strands to the work, and I think this is important from a training perspective. We really want staff to understand there's always a cause of challenging behaviour. That's the first stage. I have feedback from clinicians, from staff members, from trainers saying the behaviour happened out of the blue. It doesn't. There's always a reason for that behaviour, and we need to understand what the causes are, whether it's a clinical condition or a breakdown, failure in how the care was delivered. Once we have an understanding, then we can implement simple solutions. And the guidance, it is guidance, but it's very practical. It's guidance-based for staff, for trainers, for other clinicians, for security staff, etc., across the board on simple but key strategies to prevent and manage challenging behaviour. So it's a document that really feeds into training programmes as well. We essentially want challenging behaviour to be prevented. And again, this is the key approach to our guidance. It's really about staff having positive attitudes, about greater tolerance. I talked about zero tolerance. This agenda is about staff having more tolerance. And it's about compassion and being able to build a relationship with the patient. I think this is where mental health colleagues in the acute sector particularly are particularly valuable, because acute staff can really get a grip on how do you build a rapport and a relationship with the patient, and that's really important. Also, I think it's really important on staff recognise how their attitudes and how their behaviour can escalate or de-escalate a situation. It's not always recognised by staff, and I think that's a key message going forward as well. And then what we want to do is highlight a good care plan, key principles for good care planning, and that's what we got in the guidance. We've got, the guidance is broken down into key sections. There's guidance there for doctor staff to be able to diagnose the clinical reasons for challenging behaviour. Then there's a guidance for care strategies, for nurses, for allied healthcare professionals, for healthcare assistants. So there's a collective understanding on how to prevent challenging behaviour. And then obviously we want staff to be able to manage a high-risk situation. We want staff to recognise that their interaction plays a part in the escalation of a situation. We want staff to be able to simply diffuse and de-escalate a situation, and then we also provide principles for restraint. When is physical restraint appropriate? Physical intervention is appropriate, it's certainly in the acute setting, if the individual needs urgent health care. And I think that's kind of the distinction in the acute sector. If someone needs emergency treatment and care, then physical intervention might be needed, but again, as a last resort. But again, the principles for restraint are that if someone can demonstrate that, if it can be demonstrated that the individual lacks capacity and you're acting in their best interests, you're on the right roads. What we're talking about first is staff being able to understand, and this is really the first port of call. In acute hospital in particular, challenging behaviour results as a result of acute or chronic illness or ill health, working in isolation or in combination. So we want staff, and we identify in the guidance the types of illnesses and ill health, chronic or acute, that we're talking about here. We also signpost the main causes of challenging behaviour, and I think that's important, and we categorise them into physical, environmental, psychological, emotional and cognitive reasons for challenging behaviour to give a framework for understanding. We also really want to develop staff awareness and understanding of this issue. Again, we've conducted previous surveys of healthcare staff, and up to a half in certain sectors still see low-level types of incidents as being part of the job. We want to break that perception that this is part of the job the staff should actually put up with on a routine basis. And again, by drawing their attention and understanding challenging behaviour, that's the first road to raise that awareness. Again, we also want to draw a definition of what is challenging behaviour, because again, it can include those less risky behaviours that make it still difficult for staff to implement care properly. So the non-compliant behaviours, the type of passivity or fatigue that patients may have as well, that is challenging behaviour. Staff have to make an intervention to treat or care for that individual. And we're making the clear boundaries for staff's understanding there as well. But really what I'm talking about is it's a vulnerable population group, and we want staff to implement the proper care measures. The common theme for this, in terms of challenging behaviour, there's usually some form of communication barrier that leads to a person's distress. And again, one of the key strategies is staff to be able to communicate and have strategies for communication with that individual. We also want staff to be able to manage risk. And again, Our experience is that a lot of risk situations lead to restrictive interventions. We want to change this approach through the guidance. The guidance outlines essential strategies to defuse and de-escalate situations before staff call for assistance from security and/or from the police as a last resort. So we want to try and give staff the ability to be able to de-escalate themselves. Again, we also know that during the difficult confrontational situation, staff can also become confrontational. And we need to acknowledge that, but we also need to advocate the approach that means that staff remain calm, remain non-confrontational, even in a risk situation. Can they retain positive attitudes? And again, the approach is listening and talking to the patient. That's important. When we were putting this guidance together, NHS England approached us and they wanted to make sure that challenging behaviour that's a result of a clinical condition really gets acknowledged, and that if someone has a life-threatening illness or needs emergency treatment, they get it. So again, the first priority for staff in the acute setting in particular is to see whether, look beyond the behaviour, do they require urgent life-saving treatment and care? If so, is a physical intervention necessary for that immediate need? Even in a high-risk situation, there's a lot of teamwork, a lot of information gathering. Even when something is escalating, staff should be able to call on the expertise of the ambulance crew who's delivered the patient to the hospital, to other staff where there's been a handover, to the patient, to the carers and relatives to ascertain the reasons for the distress. There might be some very immediate causes of that distress that can be dealt with instantly on the spot, and that could alleviate the situation. It might be the person just wants to talk to someone and actually discuss why they're frightened or anxious. And again, we're giving staff these simple strategies to stop it escalating any further. But again, we also want to highlight some immediate solutions. For instance, pain relief is a big one. Is the person in pain? Do they require some kind of pain relief? Is there some kind of cognitive impairment, which means the environment's overstimulating? And would they prefer to be moved to a quiet area or a separate ward or room? Can the watch or wait and leave and return strategy be important? When someone's transferred from one care setting to the next, that can be incredibly traumatic. Again, will their behaviour subside over time without any more interventions being necessary? Can the behaviour be tolerated within the confines of a ward without having to make an intervention? So we're looking at very simple practical steps that staff can talk where there's a breakdown in care to really try to get the grip with what are the reasons for this person's behaviour. But also we want staff not to work in isolation, but seek support of mental health and learning disability colleagues where they exist. Is there a psychologist that's available who can provide expert advice as well? Consider whether observations are necessary. Acute sectors are incredibly fast-paced environments. Staff have very little time with the person. So that's why these approaches are very practical-based for staff. But also, can special observations play a part? Functional analysis is important, but it may be important for the most complex needs in the acute setting only. In mental health, obviously, in learning disability services, it's much more widespread. What we're talking about here is a group of staff, general nurses, who have very little time to make a judgment on that person. Then we want to make sure that when the situation does escalate, the staff member really follows a proper protocol for that. Do they put security on standby? Do they call security or police as a last resort? Do they trigger an implementation plan? Is there a proper implementation plan to trigger in the first place? And following an incident, we've talked about a debrief as well. The importance of debrief cannot be overemphasised. Not only debrief to actually provide emotional support for the person, but also provide learning objectives as well. What can you learn? Keep them separate, but include the two together. And again, finally, what can we learn? What are the lessons we can learn and feed into the care planning for the future? Prevention is the key, and again, I'm conscious of the time, but I want to go through this important part of the guidance. Again, it's all about high-quality individualised care, putting together a proper care plan, which involves the patient really in the centre, the patient making choices, promoting their independence, giving them the confidence, their health and well-being. That's what we're talking about here. It's a team approach. There's no good if there's a care plan for an individual patient and only half the team know about it and know what the strategies are. Because if another member of staff comes in who's not aware of it, if you have temporary staff that are working with the individual, if you have healthcare systems where the information has been shared with, that care is going to break down. So we need a shared approach, and that's vitally important that everyone knows the reasons for this person's behaviour and know the strategies to prevent and manage it as well. So it's about a team approach, is everyone having a collective understanding through what are the historical factors for the person, what's their current presentation, what's their life story, their personal profile, and really getting an understanding of what causes their behaviour and how can you alleviate it. Healthcare staff, especially in the acute sector, are very task-focused. It's a very fast-paced environment. And again, even with a task-focused environment, staff can talk to the person. If someone's distressed or agitated, find out the reasons why. And we're emphasising staff must try and do this within the confines. But also for organisational managers, for senior organisational managers, to look at the care models. Does this really draw out the compassionate and empathetic skills that we know that staff who work in the health sector have? Staff are empathetic. They are compassionate, but they don't always have the opportunity for this to come through. And we need to really draw on this and bring this out a lot more. The guidance includes a care model for prevention of challenging behaviour. This care model covers communication, the environment, meaningful activities, promoting independence and mobility, sleep and rest periods and nutrition. And we think that package together is a good starting point for looking at how do you prevent clinically related challenging behaviour. Again, once the strategy is in place, is it having the desired effect? The proper process is following through. Do you need to review the care plan? Are there other behaviours that come apparent? Do you need to review it, implement new strategies? That's what we're talking about in terms of closing the loop for the care plan. Training, well, there's various training models. The guidance has a training model that we recommend as a possibility for challenging behaviour awareness. Very limited resources for acute staff, but all trusts to get frontline staff through training. What we're recommending in the guidance is an enhanced CRT package. CRT is brilliant at diffusing violent situations, but it's not suitable for someone who's got a cognitive impairment, who's someone who cannot communicate in a conventional way. So what we're advocating is CRT and challenging behaviour awareness as a combined unit of training to meet both sets of needs. However, challenging behaviour awareness can also be incorporated within other dementia or learning disability awareness training, or it can form a standalone training piece as well. That's not the end of the story. What we really need is for staff to have role-specific training. If they need to do an ABC function analysis, they need to know how to complete an ABC chart and the part it plays in someone's care. They need to really understand how to deliver personalised care. Again, for medical staff, it's how to diagnose the medical reason for challenging behaviour. So there's role-specific training as well. In emergency situations, staff at high risk, there might be positioning training that's needed where you need to deliver emergency treatment and care. And obviously for response teams, there might need to be more physical intervention for emergency and crisis situations. We've got very detailed guidance, just really last few minutes really. What resources do we provide to support this? We've got a very detailed guidance document. We've also got challenging behaviour awareness training, a series of videos that support the guidance. The videos are based on clinical and non-clinical staff, all for staff who have a direct patient care. I think it's important that these videos apply to them. And for instance, one of the scenarios involves someone with learning disabilities in an outpatient unit. It's asking the receptionist that de-escalates the situation because they've had a conversation with that person's carer on what are the background to that individual and what are the ways they can be calmed. So again, it's a collective approach, and that's what we're getting across in this guidance as well. It's a versatile resource. It forms themes around introducing challenging behaviour, prevention and care strategies, including the environment. There's an extremely good environment piece for dementia on there as well, and then how to manage the risks of challenging behaviour. So I think there's something for everyone. It covers acute illness and ill health, chronic illness, learning disability and mental ill health as well. So it's very broad across a range of medical conditions. And I think that the real strength of this is each scenario is based on real-life examples, and we've tried the videos in the Annbrooks Hospital, and the feedback is students can really empathise with this approach, and they really generate a lot of discussion and good strategies to prevent challenging behaviour. It's a short, versatile resource. It can be used as part of blended learning, face-to-face e-learning, but it can also be an off-the-shelf package for staff as well, and I think that's really important. We've got a set of learning outcomes that support the videos, and they're based on developing an understanding, developing a prevention, and developing a managing strategy. And again, the guidance and the videos are supported by a standalone website, which again, we launched at the end of last year. The website is dedicated for staff who want to understand, prevent and manage challenging behaviour. It's based on a summary version of the guidance, but everything, and I urge you to look at it, it's free to download. It's all free resource that you can use as part of the training. It's been designed so it's viewable on mobile devices, on tablets as well. What we want is staff on the wards who haven't got a lot of time to bring this up, look at simple strategies to de-escalate behaviour and implement them in real time, and that's really important as well. We've had almost 17,000 hits since we launched the website, 13,000 unique visitors. This shows this is a real burning issue for staff. We had a recent inquiry from colleagues in Hungary for a not-for-profit organisation who want to use the resources in services, developing services for people with autism in health, education and social care. So this, as mentioned before, this is a global issue. This is not something that's unique to the NHS. It's across countries, across continents as well. What we also want to do with this is really have it as a resource, not just to highlight the latest events, the latest conferences like this, but we also really want staff to be able to share experiences and share best practice. And there's a section on this website where staff can email in videos, guidelines, anything they've developed at a local level, and we'll look at it, where appropriate, share it on a national level. And I think that's important. I go to events like this, and I really hear lots of pockets of great activity that's going on, but we want to share that nationally. Pockets of activity on a ward that the organisation doesn't know about. It's important that everyone gets to know about it, so we want to share this where it's appropriate to do so. Finally, just wrapping up really, what is the future for this work? Well, we've issued the guidance, the website and the video resources. That's already gone out. What does the future hold? We want to start to the implementation of this project is already underway. We want to start to evaluate this work programme ourselves and to see what impact it's having on the NHS. But again, it's really for Trust to grapple with how to implement this programme. From an NHS perspective point of view, this arrangement, this guidance is mandated by the Health and Safety at Work Act and the legislation that underpins that. So from an organisational point of view, they have a responsibility to ensure the health, safety and welfare of its employees and to assess the risks and decide how best the risks can be prevented and controlled. So not just from a care angle, but from a health and safety point of view, it's important that really organisations take a lead on this in terms of the implementation. I think organisations are really finding this quite overwhelming in some areas in terms of how do they implement this and how does it fall with the positive and safe and all the other sets of guidance that's out there. So it is important, I've heard it mentioned throughout the day, that an individual champion or an implementation group implements this as a package around positive and safe and really rolls it out. But the importance of the board level support for this work, again, cannot be overemphasised. You're not going to get anywhere in terms of a consistent approach across an organisation in changing the culture unless you've got board support and backing. And that's a key message again. I've heard, again, about lots of best practice in some areas of an organisation. Is it consistent across the organisation? That's what we're talking about here. Finally, just to wrap up really, evaluation of this work is problematic. But again, we do support the good governance for organisations to take this forward. We also support the openness and transparency when things go wrong, and I think that's important to be open and transparent. The recording of restraint incidents that lead to patient safety incidents on the NRLS is a good starting point here. But we're really looking at what meaningful outcomes can measure the success of this work, and I think that's important. And I think it needs to match across the violence. So has there been a reduction in violence and aggression incidents? That's important as part of this. So map it across the violence and aggression strategies. We'd like as an organisation to try and map across violence and aggression that's resulted as a result of restraint being implemented. And again, we need to see whether we can get that data. Has there been a reduction in restraint? That on its own is not appropriate, but it's a good starting point. Has there been a reduction in patient safeguarding incidents? Again, has there been a reduction in incidents where the police or security staff have been involved? There's lots of potential measures here, but again, the picture in terms of data is incomplete. The big plan for us, finally, is really, we'd like to really get this at source. Again, we'd like to implement this into pre-registration nurse training and training for the healthcare staff as well. We talk about good practice on the wards, but actually you need to get staff involved at a training level, at the pre-registration level. I speak to lots of student nurses and other student staff who are trying to deal with this agenda. They get nothing in terms of this training in pre-registration training. You've got to get it at source, because when they get onto the wards, when they get into an organisation, there's not a consistent approach. So you really need to tackle this at pre-registration level.
We've got a few minutes left now.
that's actually a good prompt for me to finish, really. That's the big plan, and that's what we're going to look at going forward. But I really, just to reiterate those key messages, it's about prevention, it's about all sectors, but the acute in particular, and it's not just about patient care. That's vitally important. It's about staff safety as well. Thank you very much.